Good morning. My name is Dr. Dan Simon. I'm the Chief Clinical and Scientific Officer of University Hospitals and the President of University Hospitals Cleveland Medical Center. I'm joined today by a special guest, Dr. Joan Zoltanski, who's a pediatric critical care physician, the Chief Patient Experience Officer of University Hospitals, and now with a very important role as the Director of our Healthy Restart Recovery Group. Welcome, Joan.
Thank you. Thanks for being here.
So as we often do, we like to say good morning to our friends and supporters across Northeast Ohio and in Florida. And for those of you in Florida, you've made a good decision because I woke up to snow this morning in Moreland Hills. I don't think I've ever seen snow after Mother's Day, so so much for global warming. But it's great to be here, and we're going to do our customary summary of how things are going. And again, I'm coming to you with a great deal of optimism, but again, a little bit of cautious optimism, because we've seen across the United States and in some parts of Ohio, little signs of micro surges of activity that we'll talk about. So overall, 24,081 cases in Ohio, a decline. Our 21-day average was 594 cases a day, down to 384, 1,341 deaths. The average daily was 41, down to 10. And ICU admissions, which is obviously a very important sign of severe illness, the average was 21 a day, is now down to 5. So that's really good news. And hospitalizations are down nearly 40% overall, from a 21-day average of 85 a day down to 24. So we are continuing to see a steady drop in the number of cases, but do want to point out a little different than some of the other countries we've been following, where you're reporting the number of days with no cases whatsoever. University Hospitals is stable on a little sawtooth between about 60 and 75 cases, sometimes a few more, a few less, but certainly very manageable across the health system. So May 1st, the governor allowed us, as many of you know, to launch recovery for elective procedures, or what we say non-essential, and we've seen a great uptick in activities across the health system. Nothing made me happier than to see us perform over 100 surgeries at Cleveland Medical Center on Friday, understanding that our nadir had been as low as 30 cases a day. So really nice recovery. But everyone's here to see you, Joan, not me today, because it's all about restart. And there's a lot going on in the state with the governor. Big days this week, barbershops and salons, that's really important, restaurants and other things. And so can you tell us a little bit about this incredible group that you're leading related to Restart?
Well, certainly it's been a hot topic. As you know, there has been a lot of interest in the community from this, from leadership in the community. And really this body of work started when COVID started. Many leaders in the organization and many clinical leaders are infectious disease doctors, infection control doctors, specialists in testing. Many leadership, much of the leadership of the community were reaching out to talk and say, what is this? How do we conduct our organization during this time of COVID? And we certainly have tried to respond to many of those needs as we can with information. But as the governors around the country said the word restart, all of our phones and emails started lighting up again, asking for information on how to do this in a healthy, responsible way. So when we thought about going back to work in Ohio, we took a very thoughtful approach and convened our experts and started talking about how can we help people when we restart. So the first thing people often like to talk about is when. What is the right time? Is Friday the right day? Is May 18th the right day? Those kinds of things. We know that businesses are going to restart, and we know that it won't happen in a time when COVID is completely gone. So what we're focused on, as importantly as the timing, is how businesses restart. What can we do? What advice can we give? How can we share our best practices because in university hospitals, we've been conducting operations during COVID. So in addition to treating patient to patient, we've also been running services during COVID, so we have some operational insights into that. So as you know, about 2 weeks ago, we convened a group of experts in a physically distant manner to respond to the needs of the community leadership and put information in a way that is hopefully usable, and we'll look at some of it today. But really, it's been a response from the big outreach from the community to university hospitals, the clinical experts, and also the operational experts like yourself. You've been the executive leader of this effort in our system. So to share some of those insights with the community.
Terrific. Well, one of the things that I think you mentioned, which is really important, is to actually share the team with our friends and supporters. So maybe, Kim, if you could put up slide number 2, Joan could take you through. Who is this great team that's helping you with Restart?
So you'll see here we have our infectious disease experts led by Dr. Salata, who is our professor and a chair in the Department of Medicine. He's also a master clinician of infectious disease. And also Dr. Keith Armitage, who's the medical director for the Roe Green Center for Travel Medicine and Global Health. And you see Dr. Salata is also the program director for Roe Green. And what many people may not know is travel medicine, a large part of travel medicine is the study of infectious diseases that cross national borders. And that's what COVID is. So they've been thinking about these types of disease well before the COVID epidemic started. Also in here are physicians like Dr. Claudia Hoyen and Dr. Elisa Day, who are the directors of infection control in the system. Dr. Amy Edwards, also an infection control doctor in our system. And these are the doctors who, again, before the COVID pandemic, were thinking about if someone comes into our facilities with infectious diseases, how can we stop that spread? So well before COVID, we were thinking of many of these things. Very importantly and very in demand is Dr. Christine Schmatzer, and she is our Chief of Clinical Pathology and a director of our Diagnostic Institute. And everybody wants to listen to her expertise right now. She is a pathologist, and what pathologists do are think about testing and offer opinion and expertise around testing for COVID. Also on here you see our operational experts. So you, Dr. Simon, and Dr. Eric Beck, who's our Chief Operating Officer, who have been helping guide operations during this pandemic.
Terrific. And you know, one of the things that we want to immediately tell all of our supporters, and you'll see it at the end, is that this entire web-based playbook, as well as a downloadable playbook, is available at uhhospitals.org/restart. So you don't need to take any notes while you're listening right now. Everything is available online, including a beautiful PDF that you can download that'll go through everything. But before we take it open to questions for Macy, I do want to congratulate you on a very catchy trademark phrase that you came up with, which was screen, clean, 6 feet in between. Can you tell us a little bit about that? I know your guiding principle is employee safety and customer safety in this restart. So take us through a little bit about why is this checklist on slide 3 that you could put up, Kim? Why is this checklist just so important?
So this checklist is important because what we did is we convened our group of experts. And as you know, it was unfortunately on one of the sunny Saturdays in Cleveland, we took everyone who had already been working well beyond full time, you, the infectious disease experts, well beyond full time, and in a physically distant manner, convened them and said, what are the important things that we can share with businesses as they return to work? And the highlights really were, of course, you see in all these images, there are masks. So masking is certainly one of them, but what is a way, a catchy way, an easy way that we could coin to help share with people how you can remember your personal safety as you go into the workplace? So screening. And you see the governor talks about screening in his directives to businesses as they go back. What is the way that employees are screened before they enter the workplace around fever, symptoms of COVID, travel history to COVID hotspots? Cleaning, high-touch surfaces, deep cleaning at the end of shifts is the next one, that clean. And then also 6 feet in between, so to maintain that physical distancing as people return to the workplace. Also importantly, on this page, you see what we did is there's lots of information on websites out there, expert information, that gives businesses, employers information about how to return to work safely. And what we did is, after listening to numerous businesses, we put our information on our website, this playbook website, in the way that, like the voice of the customer, for instance, we are putting it in a way that businesses are talking to us. And what leaders of businesses and organizations, nonprofits, are concerned about is, how do I keep my people safe? How do I keep my employees safe? How do I keep my customers safe? Next is, how do I keep my facilities safe and the equipment that my employees use safe? Designed information around that. And also, very importantly, is how do I communicate? How do I lead? How do I reassure my employees and my customers that their safety is my top priority? So you see here on this, we talk about keeping your customers safe, your employees safe, and the workplace safe on this.
That's great. And I think, like any checklist, what people want is they want the ability to almost, educate their own employees and leaders within their workplace to know that this is going to be the basis of what we are going to do every day. I think it's important to point out, and we should qualify, that these are our best recommendations. They're based on CDC recommendations, Ohio Department of Health recommendations, and also our experts. They don't eliminate the risk of COVID infection. They reduce and minimize it. And that's really very important. We certainly are available for guidance and consultation. We have on the website questions that will be answered. We can't eliminate the risk, but what we're really trying to do is mitigate. And with that, Macy, we thought maybe it'd be a good time to go to your open questions that you have and the ones that are coming in, and then we'll cover these other topics within the recovery playbook as we go through.
Thank you. They're just starting to come in, but I would like to start with a couple of questions since we're already talking about the screening and the masking. Let's just go ahead and get those out there because we know people want to know about masking. When it comes to a business setting, what are the best types of masks to use? And then how do they keep those masks clean and so that they're effective throughout the day and the week?
So when people think about masking, what you also have to think about is the availability of masks. So there are certainly differences between the cloth masks, the surgical masks, and the N95 masks. But what is available to most people, and what the governor has recommended, is cloth masking. And importantly, when people think about this, which they may know, but some people do not, is the masking is to try to help prevent me, for instance, if I'm wearing the cloth mask, from catching COVID, but also if I were an asymptomatic carrier, so if I did have COVID, but I didn't feel sick yet, to help me to prevent it from spreading it to others or lower that risk.
Okay.
I think, Macy, this is a very important question, and it really depends on what kind of business you are. I think that, we certainly are recommending universal masking in all of our facilities. And for most of our employees in university hospitals and healthcare workers, these are the Cupron cloth masks. These are the masks that we talked about that have copper infused into the textile fibers permanently, are washable, and the copper itself has antibacterial and antiviral properties. Now, those are a little bit more expensive than a do-it-yourselfer, although the stylish masks now I see are selling online for up to $12 to $15 a piece, which is about the price of a Cupron mask. And I think that those are breathable and they're washable. And what we tell our employees is that they should take it home and wash it at night. So for employees that are working, in your place of business, I think supplying them with cloth masks is a good one. The harder question is what happens when a customer comes. You're trying to set a standard of masking of everybody within your workplace. What kind of mask are you going to provide them? And for instance, when you come to us now, and now that we've run out of a lot of do-it-yourselfer masks, we've distributed so many, we supply a surgical or isolation mask to someone who's coming to the hospital who doesn't have one. Those masks typically are about 25 to 30 cents. But now are more expensive because of availability issues. So I think it's going to be a mix. And a lot of the recommendations that most businesses are taking is that we request that you will wear a cloth mask when you come into our business. But that's a tough one.
Is it conceivable to think that until a business owner can get his hands on masks for his employees, that maybe he or she should hold off on going back into business?
In the governor's orders, it was mandated for businesses right now for their employees to wear masks. So you would need masks right now. There are certainly limitations of people who are not able to wear masks. So I know sometimes I'll hear comments where people will say, I went in and this person wasn't wearing and that person wasn't wearing. So to recognize there are people who are not able to wear masks and they are excluded from that. But right now, to be encouraging your employees and to find ways for them to wear masks is important.
You know, Macy, I think you raised a really important issue there. So we've talked before that when we talk about close interaction and contact, we said it was 6 feet, 5 minutes. So if you imagine a place of business, if you have multiple employees in a confined space, it's going to be difficult to sometimes avoid the 6 feet and 5 minute rule without very important, what we call engineering controls, which are typically plexiglass barriers. You see that when you go to the grocery store now, the checkout lines have plexiglass barriers. And that's because when you're in that interchange with the cashier, there is not 6 feet in between you. So that plexiglass barrier becomes a way for you to check out, even though both are typically masked now, but the distance is narrow. So I think there are other things that you can do. But you know, the governor has advised a 50% reduction in occupancy by fire code to keep the density of people down. There's still a requirement for the 6 foot distancing, and Joan will be able to share with you later some pictures that show how you have to change the office environment to accomplish that. But I would say that masking is critical because of the interactions that you have in the workplace itself. You know, there is a recommendation that if you can't appropriately distance, then you either have to stagger shifts, and then your higher risk individuals, right? Those over 65 or who have, you know, high risk medical conditions that we've talked about, diabetes, heart failure, lung disease, immunosuppression, cancer treatment, then you have to think about should those individuals work from home, because there is some flexibility. So I'd say it needs to be tailored to each individual situation.
Yes, and also to understand that it is masking and the physical distance. So it's not one or the other. It's not mask or 6 feet. It's masking and 6 feet.
So Bill, like a lot of people who are watching, his office is the world. So let's talk about his question. As businesses start to open up, I'll be going back as a sales executive. I travel, I call on people one-on-one. Sometimes I drive, sometimes I fly. Any specific advice for me to minimize my risk as I travel? I will need to meet with people sometimes, person to person. What is your advice?
So still to maintain that physical distancing where you possibly can, if you can, of course, possibly do it remotely is best, but to maintain that physical distancing and masking as you do it. And also importantly, which we haven't touched on, which we really need to highlight is the vigilant hand washing. So vigilant hand hygiene as frequently as you can, making sure that you have hand sanitizer with you and that you use it correctly is important. Also in travel, there was some literature that came out in the past year or so to tell you that not that I'm, saying that this is the be all end all, but that the window seats have less bacteria than the aisle seats. So that's one thing that you could consider. But I think most importantly are those key recommendations of hand washing, that cleaning. When you think of the screen clean 6 feet in between, that cleaning personally is around hand washing, vigilant hand washing. And then the 6 feet in between is the physical distancing.
There is some concern from Andrew that perhaps the governor jumped the gun just a little bit. And I don't know that you want to get into the politics of things, but, was talking originally about staggering openings, and now that's not necessarily happening. From a medical standpoint, would you like to share your thoughts on where we are as a state? This is what we've been dealt with. So moving forward.
Yeah, I really feel like my role as a leader and as a physician is to comment on how we can safely go back. As I said in the opening comments, there is not going to be a day where we have a restart and we don't have COVID. So we have COVID, there is a restart plan, and this whole body of work is around how can we help do this in the safest way for our community.
Yeah, I think, Macy, we've talked about Governor DeWine and Dr. Acton, and you just have to look a little northwest to Michigan to see really a tale of two different states. What's happened in the Detroit area and in the Beaumont Health System and Henry Ford and Detroit Medical Centers and others is very, very different. They experienced a massive surge, and that was really secondary to the fact that the declaration of the state of emergency, the stay-at-home order, and the physical distancing was not accomplished in the same way. So I do think we're in really much better shape than our neighbors are, and even a little further west in my hometown of Chicago. Much bigger problem, and a lot of that has to do with the density of the city, how people commute on public transportation and others. So I think in Ohio, we are in a much better position than some of our neighbors. Now, that said, there are frustrations, and I acknowledge that, about when is the right time to go back. Is it true that younger individuals can have more mild disease? There's this issue of herd immunity. Should we be doing what Sweden did instead of what we're doing here? Those, I think, time will tell, and we'll learn about pandemic management down the line. But I agree completely with Joan that right now our job is to understand what's being recommended through the Ohio Department of Health, and then try to minimize that risk for our community, not only our businesses, but our nonprofit organizations, our churches and synagogues and others. How are we going to get people back together in a safe way? And that's what we're trying to focus on in the Restart website and in the playbook.
And I know that every governor in the country is struggling with this. There is not an easy answer. There's not one place in the country where it's safe to flip the on switch off, and then also that it's risk-free to say no and go out. There are consequences either way, and the governor has admitted that in his decision.
John brings up a question that is probably on the minds of a lot of people. So after 2 months of stay at home, social distancing, 1 month of public masking, what are the origins of the new cases of COVID-19? How are people still getting sick?
So people are still out in the community, and anytime we have people out in the community, there is the chance that we will spread this disease. Masks are effective, but they are not 100% effective. So we're talking about these strategies to help reduce COVID, but as you mentioned in your opening comments as well, these are not strategies to stop COVID. So it will be spreading. What we're trying to do, as we've said since the beginning, is to flatten that curve. And these are strategies to help slow the spread.
You know, Macy, we still are seeing that the predominant majority of new cases in Ohio are in those high-risk areas that we've talked about: assisted living, nursing homes, and congregate living. And, you know, just this last week, we now have what we expected is that the Juvenile Detention Center in Cuyahoga County, which had been spared the disease, had 3 to 4 guards turn positive. And now there are several clients of the Juvenile Detention Center which are now positive. So we know about the outbreaks in jails and prisons. These obviously are brought in by guards and people who work in these jails and prisons, because, you know, the jail and prison is an ultimate quarantine place if no one can come in or come out. But the disease gets in, and of course, because of the very close proximity, the inability to social distance and mask appropriately in the prisons and in nursing home facilities and skilled nursing, it takes off. And so, you know, that's what we have to understand. And as Joan points out, because there are asymptomatic carriers, despite the fact that we ask questions, despite the fact that we take temperature, we can't eliminate it. That's going to require a vaccine, and we're going to have to wait for that, as we've talked about.
Mm-hmm. Holly has children and parents who live out of town, and they're anxious to get here and spend a weekend. It's not just about seeing the grandchildren, but it's coming and staying. What is that going to look like in the home? And is this the time to even have that conversation?
So I think that we don't know yet. This restart is going to give us more information. And when people ask me, I talk about this pandemic started, we are actually not that far out from the beginning of this. And as we move further and further out, we'll have more and more information, but we don't actually have all the information we need to answer all of the questions that people have about this. What we're doing is having the restart. We'll watch the data, we'll watch the information. And as that information comes back after this slow migration that the governor is setting out, we'll have more information to think about when are things like elective travel going to be something that should be integrated into people's lives.
You know, Macy, I think I agree with Joan completely about this is learning in process. So as many of you know, when we restarted our elective procedures, we made a decision in the health system to do viral testing with PCR for every patient undergoing elective surgery or an elective procedure for the most part. There are some exceptions. And we did not know the rate of asymptomatic carrier of the virus. That's something that people have talked about. How many people are having the virus before they have any symptoms at all? And interestingly, and I think very reassuringly, it's very, very low, less than 0.5% for sure in the first 800 to 1,000 people that we've tested. So that at least is reassuring to me that if you take 800 to 1,000 people who have been set up for an elective procedure, that's the caveat, that their rate of asymptomatic is very low. Now, these are people, for the most part, who've been very compliant to physical distancing because they're willing to say, I haven't been out, I know I'm healthy, and I want to have surgery. And that rate is very, very low. So one could imagine, in answering your question, if both families have quarantined very tightly over the past 14 days, no one's sick, no one has any symptoms, and there isn't someone who's particularly high risk, and this has happened, of course, with Mother's Day, because we know it's happened, a lot of these families have decided to say, we'll come together with masking, and we'll try to keep our distance. Of course, when we eat, we'll take our mask off. So they've had what I would call our kind of distant Mother's Day experiences, sometimes in 2 different rooms. But it's the start of that notion that we are going to have to relax a little bit. And there is some confidence that if you've been quarantined for 14 days and you have no symptoms whatsoever, that the risk is very low. It's not zero, though, and it really depends, for instance, on what is the health status of the grandparents that the family are coming to visit. If they're high risk, that person needs to stay masked the whole time.
But I think, like the restart orders, it's all a risk. It's just a question of how we can best mitigate risks.
We have a question about restarting daycares, and I think it's too soon to tell. I believe the governor is going to talk about that today. But the scenario that Hank suggests is that his child need to wear a mask. Will the same amount of children be allowed to go back, or will they need to be separated? I mean, there's so many unknowns.
And so there have been some daycares that have been open during this across the country to take care of children for people who are working in essential services. So there have been some, but of course, many of the daycares have been closed. What they're thinking about in reopening daycares is children being asymptomatic carriers of this, and could you spread it to another child who may not get symptoms, but could take that back to their home. So that's one of the things that they're thinking about in that. And also in this COVID pandemic, we have had some reassurance that children largely have been spared. There have been some case reports in the past couple of weeks. There was an article in the Lancet last week about some children having what people have concern is that it's an effect of COVID after after people have had the disease and they're not symptomatic anymore, that some children had some very serious illnesses. They're not sure it's associated with COVID, but it's really the first information that we've had in the world of pediatrics that there may be something more going on. So we'll be watching that closely in the world of pediatrics. But I think for the daycares, the concern is there asymptomatic spread in children when they are not aware to take that home? But we'll be looking forward to what the governor says.
This question comes from a healthcare vendor. What communications have been outlined and perhaps executed to those of us who call upon UH physicians, visit your hospitals on a regular basis, specifically radiology, for example? I think when they walk through the doors of UH, they'll see a very different waiting room. Correct.
When you come to UH, before you enter our facilities, you will be screened. You will be screened with a temperature check. You will be screened with questions around any symptoms that are related to COVID and also around travel history. So people are not allowed to enter the facilities unless they are screened. And of course, we're asking for masks, as we said, and also reassuringly for me is in the outpatient space as well. We're doing that. We want to encourage people to come back for their regular care in the outpatient space as well. So your regular doctor visits that people are concerningly putting off their regular care. And so we want to help to make sure that we're getting people their regular care. So vendors, patients can be assured that before you enter our facilities, people are screening and there is universal masking at screening.
You know, Macy, I think it is worth commenting specifically on this question, though. So right now, as you know, we have no visitors to the hospital other than someone who's coming for surgery There can be a pre-surgical visit and then a very brief visit after surgery, and then there are no visitors. We right now have no vendors able to call on university hospitals unless you are a clinical specialist who participates in a very technical aspect of a procedure and procedural planning. We have not made a decision yet on when we're going to relax the vendor policy. And that's because we're trying to keep the hospital, as Joan said, a very safe environment. And as you walk around, it is a very different place. There's not the same life and noise and people that you normally see in a hospital that you would expect by having, nearly 8,000 employees working here and people coming and going. So it's much quieter and much more controlled. It's in some ways a much more healing environment now, which we'll talk about because we've noticed a very interesting thing, and maybe Joe, maybe this is the best time, is that one would think that patient experience might deteriorate during the COVID pandemic because families have no visitors, and because we're limiting the number of caregivers who actually go into a room. And yet, completely, I think, surprising to me at least, is that our patient experience metrics have gone up. So what have we learned about how we're dealing with patients, communicating with patients? What technological advances have you put into this to make things better as our Chief Patient Experience Officer? Because you've done something special here, Joan.
Well, thankfully, over the past number of years, we've had a lot of great success in patient experience. We put a lot of concerted effort into this in our system around our effective communication with patient from our clinical providers, from our front desk staff, all of those matters. But during this time of the COVID pandemic, our strategies around that had always been around patient communication, really getting back to this fundamentals of great patient care, which is that relationship between the clinician and the patient. And so when the pandemic came, it really upended a lot of our strategies around getting people back to the bedside because we were trying to limit the number of people who go into the rooms to try to prevent the spread of disease. So going in for essential things, but for elective matters, waiting on that. So what we have done, thanks to some of the supporters in UH, we now have iPads that are available to the patients and to the nurses and to the physicians. So we have an iPad that stays at the patient's bedside where when someone does come into the room, they can call the patient's family. And this is very important for patients. They want to see their families because visitors are limited right now. They can't come in. And so this communication that we have now, this triangle between the clinician, the patient, and the family at home has been very important. And I think also importantly, in the patient experience scores, you may see some of this, which is, and you see it a lot in the patient comments, which patients are talking about how grateful they are to the clinicians who are there to take care of them, who are there to call their loved ones at home and update their loved ones at home. So part of it is the technology piece that we have stood up with the thanks of our UH supporters, but also people know that everyone in UH cares. And I think, an example of it was this body of work. I called on people like yourself, our infectious disease doctors, who were working really nonstop during this pandemic. And when I asked everyone to come in on a Saturday and work on it, the answer from every single person immediately was, yes, where do you want me? Where do you need me? So that dedication of the UH family to our patients is really shining through right now.
Yeah, I think it's really very interesting. And I do think you're absolutely right that because we don't have visitors, but the transitions of care, the planning of care is so important. Now that we're reaching out to the family in a more intensive way, because we're trying to supply the information that they don't get by being there, somehow it seems that the communication quality has improved. And that was why today, I woke up this morning and I had an alert from Statit, which is our patient experience alert. And of course, I expected the alert to be that it was going down, and it was at an all-time high. Communication with doctors was nearly 92%, was rated as the highest. And I was very surprised. So Joan and I have been talking about this, that this is one of the silver linings of the COVID pandemic, is that we're finding out that there are maybe more effective ways for us to communicate. And what we hope will happen is when we do allow visitors to come back, that we'll still take the time to communicate as effectively with them, present. So
Yeah.
congratulations though, because it hasn't gone down, it's improved, which is really terrific.
Yeah, well, again, it's thanks to the people, the clinicians, and everyone who's supporting clinicians on the front lines that's really making this happen.
When people do start to come back, they will see a different UH, and maybe perhaps this is a time that we can take a page from the playbook and share what we've learned with businesses about how to set up their space for the most care and for the visitors and the employees.
So if you look at slide number 4 in the slides that we provided, you see some practices that we are sharing. And this is an employer story where you see the first touch point with the workplace is the screening, like we talked about. So screening your employees, and also the governor talks about this, for fever, symptoms, travel history. And then also you see examples here of how to physically distance in your workspace. And I think importantly, when you look at these cubes on the second, on this second image, is there aren't chairs at some of the cubes. And so what we want to do is not only talk to people about physical distancing, but to create the culture of physical distancing, to remove chairs, to remove tables in restaurants, those types of things, so that people don't have the choice of sitting 6 feet close to each other within that distance, so that you create that culture. Of course, working from home. And then also on the fourth image, there have been a lot of questions about food. A lot of employers they have cafeterias, they have break rooms. A large part of how we socialize and become community is sharing food, potlucks, somebody's birthday, those kinds of things. And now is not the time for community food. So we're talking to them about grab and go items that they can have in their workplaces to help their employees stay safe. And then also, again, on that sixth one is the physical distancing. On slide 5, we have some other examples, suggestions for businesses. And you see some examples here from restrooms where we've talked about closing off faucets, every other faucet, closing off bathroom stalls. And part of that is to help with physical distancing, but also to decrease the density in those spaces. So asking people to wait outside to decrease the density of people in that area together. Same thing about decreasing density in the conference room in that image on slide 5 at the top right, where you see the conference tables, just removing those chairs, so not taking those chairs out. A lot of questions about elevators, and it depends upon the size of your elevator, but certainly reducing the number of people who are allowed in elevators at a time. Whether if very large elevators, it could be more, but in very small elevators, it may just be one person allowed in that elevator.
You know, and I think one of the things about that is in trying to not enforce, but to make nice suggestions, you know, helpful signs can be very useful. So as you go into stores, I was in CVS this weekend, you see little footprints that have 6 feet where you're supposed to stand. And, you know, we'll be placing those same types of things in the corners of the elevators to try to encourage individuals to go to the corners of the elevators. And even in our waiting rooms, because they are trafficked and people want to move them, there are little stickers on the ground that are trying to indicate, keep these distant chairs in this particular location. You know, we're also using some simple technology like wait in your car for your appointment, and we'll text you when it's time to come in. So you won't wait in the waiting room. We pre-register you. You'll wait in your car, which is very, very safe. The text goes off. You come right into the room to see your doctor, and then home you go without having to wait. So I think there are things that I know a lot of businesses are going to be using as well. Dentist offices, barber shops, salons, I've been hearing, are going to be scheduling patients that way with the text and wait in the car.
And this is a good point to talk about. Many businesses are asking me how they can reassure their employees and customers as they come into their business that they're taking this seriously. When I go into a business, if I go into a retail space or a restaurant space to pick up food, what I want first is physical signage that says, your health is my top priority. We are screening our employees. We are masking. We are physically distancing. So even before you enter, to have signage to reassure people, people want to see that. Also, what we talk a lot about right now is cleaning high-touch surfaces frequently. And so when people are using shared computers, shared phones, countertops, those kinds of things, we clean those surfaces, but also it's a great idea right now to let your customers see that you're cleaning those surfaces. Sometimes we try to restrict that cleaning at night. so that customers don't see that. And then we think if they come in, they must just be reassured knowing that we're doing it. But this is a good time to have your customers see that you're doing that. So having people on the floor cleaning those high touch surfaces while people are in there, masking, and then those physical barriers, those environmental controls like the plexiglass to see, it shows your customers and your employees that this is top of mind, their safety.
For offices, are there ventilation systems that we should be looking at right now? Would that make a difference?
Well, there are HEPA filters, and the most efficient thing for you to do is to contact your engineer and consider placing a HEPA filter as opposed to a normal filter. The HEPA filter will screen 99.99% of viral particles and bacteria, and that can be a very efficient and cost-effective way of doing it. If you don't have the ability to control your ventilation systems, you can purchase HEPA filter systems that look a little bit like, you might say, a dehumidifier, about that size. And what they do is they bring the airflow in, filter out all the viruses and bacteria, and then put filtered air back in. And in a typical sized HEPA filter, which you'll have to read the square footage, you can clear all the air in about 5 to 15 minutes of a room. And so if the room is large, then there's a recommendation to use multiple. And those can be purchased online. And that's HEPA, H-E-P-A filter, and they screen viruses and bacteria. You know, airplanes have HEPA filters, some airplanes. So if you live in a big city and you have a modern fleet, all of the modern airplanes do have HEPA filters. Unfortunately, Cleveland has some of the older fleet. And so the general recommendation in the older fleet where they don't have HEPA filtration is to close your air vents and clean all your surfaces when you're on an older fleet airplane.
The HEPA filters, support of them, and a great idea, but having that occupancy at the governor's suggested rates and the number of people in rooms, you know, if you take your occupancy and you decrease it by half is the suggestion right now. So it's important to look at those HVAC controls, but also to make sure that the first control you have is the density of people in the room.
Can you update us on the status of clinical trials? And while we're at it, it might be a good time to update on the status of antibody testing,
Sure.
because I would think that a lot of employers are looking at that as their staff come back into work.
Sure. So the clinical trial story is really an amazing story for university hospitals. We were very fortunate. Grace McCompsey, Dr. McCompsey, who's a pediatric infectious disease physician and runs our clinical research center, was able to get us into some really critical trials very early on. I think the most prominent of which is the Gilead remdesivir trial, which reported out. So those of you who haven't joined us recently, that remdesivir given once daily IV reduced hospitalization stay by over 4 days and reduced mortality from 11.6% to 8%. So even impacted on mortality. So as many of you know, Gilead has offered to make that drug available under emergency use authorization. But if you've been following the news this weekend, the distribution of that drug has been very controversial and for the most part unavailable. The good news is that it is available at university hospitals because we're continuing to enroll patients in the companion trial comparing 5 days of remdesivir to 10 days. We've enrolled 78 patients in that trial as of last evening. And now every patient in the hospital who has COVID, the question is, why are you not being enrolled in the trial? Because we can tell the patients that there is a benefit. So fortunately, we continue to have access to the drug. Many of you know about our 5,000 patient ARMS-1 oral spray antiviral compound trial for healthcare workers. That had to get a final IND from the FDA. That will start enrolling, we hope, this week. And that'll be trying to prevent COVID infection within healthcare workers themselves. We have 2 trials that are starting up this week. One is a convalescent plasma trial for our sickest patients in the intensive care unit. And we still have across the system about 45 patients in intensive care units. So this will be giving them convalescent plasma from patients who got over an infection, and these antibodies will neutralize. And we also have an anti-inflammatory trial, a potent antibody to IL-6 called tocilizumab, which dampens the inflammation that really drives lung injury in patients who are in the intensive care unit. Last week, again, we want to just convince you how innovative University Hospitals is. We enrolled the first patient in the United States in a mesenchymal stem cell trial for patients in the intensive care unit with COVID viral pneumonia. This is a concept that your stem cells, which are off the shelf, in this case, a mesenchymal stem cell, dampens the immune response in the lung. That's a company called Athersis, which is based in Northeast Ohio, and our own Frank Jacone enrolled the first patient in the intensive care unit at Cleveland Medical Center last week in the US. So a lot of good trial activity. For your second question, Macy, I'm gonna have to go to a figure. So if I could have Kim put up slide number 6. This is a very, very useful figure, which hopefully will take away some of the ambiguity for our friends and supporters of what exactly are we measuring and when. And so what you see in this dotted line, in the vertical dotted line, that's when symptoms start. And you see the blue and the pink and the orange line. That is the viral PCR test. And when the viral PCR test is positive and when it starts to wane and go down. And what you can see in blue is the nasopharyngeal swab. And that turns positive really first, which is one of the reasons why we measure that. And that viral PCR test, which we obtain either through drive-through or other walk-up stations now, and can be available in hours to a new test for certain patients in the emergency room in as many as 15 to 30 minutes. That's that viral test. Now, many of you ask, well, what about the antibody test? And the antibody test is the dotted lines that you see in figure 6, the dotted purple line and the dotted green line. And as you can see, antibodies are not useful for diagnosing the acute infection because they don't come up till 2 weeks after infection. So your body's white blood cells are making a response to the viral infection and they start making these antibodies. The antibodies in purple are the IgM antibodies. They come up a little bit earlier than the IgG antibodies, which are in the green. And the IgG antibodies are what provides us, we hope, with protective immunity to a COVID infection. And when we do a vaccination, vaccines work because they generate these IgG antibodies. So where are we with antibody testing? Well, the good news is we have a really good test at university hospitals, which is the Abbott-based platform that has a sensitivity and a specificity of greater than 95%. And Dr. Salata took us through a tutorial last time we were together. You don't want an antibody that detects other coronaviruses, because then if you think you have an antibody and maybe that's associated with protective immunity, you never had a COVID infection. You also want it to be very sensitive. So the Abbott test and the Roche antibody test are very good tests. I've told our friends and supporters, be very careful about antibody tests that you get an email from or walking into a drugstore or a grocery store to get, unless you know the sensitivity and the specificity, or if you ask, is it the Roche or the Abbott test? We are going to be measuring 10,000 healthcare workers and first responders with the Abbott test in the coming 2 weeks, and then that test will be available for all of our friends and supporters and all the patients of university hospitals to find out, did you potentially, when you thought you had that flu in February and you didn't do anything about it, did you have COVID? And that'll be the antibody test. So I would say stay tuned, and most importantly, my recommendation is to be patient and don't settle for a first generation test that's really not that good.
So we're talking to leaders of organizations about something similar. This is one of the most common things that they are asking is, when can I get a test that will clear employees to go back to work? And what we are talking to them about is something like what you talked about, which is there's the PCR test, the swab test, and then there's the antibody test, the blood test. And unfortunately, neither one, that if you get the results and positive or negative, it requires medical interpretation. Neither one says this person cannot get COVID again and is now healthy and safe to go back to work. It's going to take some time to understand the medical interpretation of these tests in the workplace. So unfortunately, right now, there is not a magic tests that will allow you to do that. And also, we were talking about the same thing. Many organizations are approached and they say, we can do your testing for you. We can clear people for you. We worry about the quality of those tests. We know our tests in university hospitals are sensitive and specific around COVID, but the tests that are offered to organizations outside of the healthcare system may not be.
You know, I think, again, and this is just the facts, and I know it's disappointing, but we're going to learn about this not from the United States, but from our colleagues in South Korea and Singapore, which have a much more aggressive testing program than we do in the United States. Every citizen of Singapore and South Korea is going through antibody testing. And then we'll know, as Joan pointed out, if you are antibody positive and have these IgG antibodies, do you develop subsequent infection? Do you have protective immunity? And so we're going to learn that. The other country, of course, which is really on the leadership front here is Germany, where they're really widespread testing the entire country. So we'll gain information about that. I think everybody will have an antibody test in the United States eventually. And hopefully by then we'll be able to tell you whether if you're antibody positive, do you have protective immunity? We hope that's the case. Dr. Salata has mentioned that over and over. We hope it's the case. We don't know it's the case yet.
I'd also like to let our viewers know that because this is the hot topic, our pathologist, Dr. Christine Schmatzer, we have loaded on this UH Healthy Restart website playbook that we have. We loaded her videos on there this morning, so there are many videos talking about testing because there is so many questions about testing. So her videos are up there.
Terrific. So that's uhhospitals.org/restart, which we'll show you at the end, where you can not only see the playbook, you can ask questions, but now you can see, I think, 5 or 6 wonderful videos by Dr. Christine Schmatzer.
Well, this is a big week for restaurants and for those of us who have been missing them. So what would be your advice for eating at restaurants safely? And I guess the question is, what should we look for when we walk into an establishment eventually to make sure that we're in a safe environment?
So those things that I talked about that I'm looking for are that signage before you enter the restaurant, that they let you know what they're doing. They're communicating to their customers that they are screening, that they are taking masking seriously and the physical distancing. And also when you go into the restaurants, if the tables are removed, the chairs are removed, if people are practicing physical distancing in there, and watching to see if someone is cleaning those high touch surfaces that are used frequently.
We've got about 5 more minutes, and I think that we've got video to show, so I just wanted to give you that heads up if you've got something that you want to show before we wrap up in our last few minutes.
So Joan, any concluding remarks from you? I mean, congratulations on this incredible playbook. I've heard about, almost 1,000 downloads already and growing. So any words for our friends and supporters in the coming weeks?
This largely in part has happened because of the support from the people who are watching this and many other people. But just thankful to be part of an organization where when I asked leaders like yourself and the clinical leaders who are working so hard to help, the answer was yes. And the reason the answer was yes was because we wanted to make this information available to the public for no charge, so that it's not just people that were able to connect with one-on-one, so that businesses who aren't able to connect with us one-on-one, that may be in our backyard, or a small grocer, not necessarily all the big ones, we have that information out for everyone so that we can ensure that everyone has a healthy and safe restart. So thank you to you and all the other leaders and to our supporters for making that possible.
Yeah, and I think, Joan, you've raised just a terrific point. We are so grateful for the outpouring of your support. We have 2 funds, uhgiving.org. One is the COVID Provider Support Fund, which really helps the caregivers at the bedside, everything from meals, educational support, personal protection equipment, and others. And then the Community Support Fund, which has really been the fuel of our research efforts. Without the Community Support Fund, we would not have all of these innovative clinical trials that we talked about earlier. So we want to thank you for that support as well. And just to give you a notion of how important that is, the antibody testing of our 10,000 caregivers and then the first responders of the 110 EMS institutes that we have medical command over is actually being supported through grateful patients, friends, and supporters of university hospitals. And we just want to thank you for that support. It means so much to us. Well, I think I want to conclude by really turning it over to the video. You're in for a treat because Kathy Sila, our chair of neurology and the co-director of the Neurologic Institute, filmed a tremendous video about the future. And what we'd like you to do is understand that this video has been downloaded almost 500,000 times now across the United States on social media, Facebook, YouTube, and many other sites. And we thought it would be great to share it with you. So thank you, Joan.
Thank you, and thanks to our viewers.
Thank you, Macy, and thank you, Kim, for all that great back action work. And we'd like to thank our IR&D team for putting this together today. See you next week.
Thank you. You stayed home. You flattened the curve so hospitals weren't overwhelmed. You took care of us. Now it's time for us to get back to taking care of you. We're doctors, we're nurses, we're caregivers. Our jobs are and always have been to take care of you safely. You have always been our top priority. It's why we got into healthcare. University Hospitals is following CDC guidelines and all of the governor's recommendations to ensure your safety. Masks for both of us. We'll provide one if you don't have one. Physical distancing in waiting rooms, spacing out appointments, and checking in from your car. Frequent and thorough disinfecting to make sure you're protected. Your healthcare needs haven't gone away, and now there's a risk to ignoring them. We're here to safely provide you with the care you need.